our weekly meeting, and we have been talking about all things COVID. Today, we have a guest speaker with us, and we are very privileged to have Dr. Harmeet Singh Rehan, who's the director, professor, and head of the Department of Pharmacology in the Lady Hardinge Medical College in New Delhi. He's a subject expert to several national and international professional bodies like ICMR, CDSCO, IPC, Central Insecticides Board and Registration Committee. He's published more than 100 original research papers in national as well as international journals. And today he is here with us talking about blood thinners. So we've talked a great deal about blood thinners in COVID times, and it's been a lifesaver, but still it brings with it lots of controversy and lots of debates. So hopefully after today's session, a lot of those queries would be silenced. After a few after his presentation, we would be opening the floor for questions. So in the meantime, if there are any questions, you can put them in the chat box. We'll try to address them as they go. So without much ado, I would hand it over to Dr. H.S. Rehan to conduct the session. Over to you, Dr. Rehan.
Thank you, Dr. Meenakshi. Thank you, Dr. Arora. I'm thankful to DMA and IMA and especially to our late dear Dr. P.K. Agarwal, who initiated such a wonderful things for a doctors, practitioners across the country, and always spoke about the need of the hour, and COVID is a need of the hour. And anticoagulants were used, misused, abused during this time, and otherwise also anticoagulants are the drugs which have a very narrow therapeutic index, and we need to see that we get maximum benefit out of it and without any adverse effect or problem to the patient. And Dr. Arora, G.S. Arora always speak about the patient safety. He is an epitome and promoting this aspect all around. And so patient safety is a concern with the coagulant because they are not very safe because of its narrow therapeutic index. At the end of the talk, I'll focus my talk on an overview of the coagulants, anticoagulant therapies. We'll enumerate some of the anticoagulants and then clinical pharmacology of the anticoagulants, mainly commonly used, oral and parenteral, merits and demerits, and their uses. Then we will see that how to convert the patient from or to parenteral anticoagulants, how they should be monitored, and especially the anticoagulant effect of newer anticoagulants and special condition pregnancy. Of course, the COVID is the one which we will discuss. And end of the discussion, I'm very sure that our practitioners will be able to select the right anticoagulant in a right dose for a right patient in a right frequency and a strength, not only for COVID, otherwise also. I'll talk brief about the hemostatic system. We all know hemostatic system. Why we need the commonly we use the term blood thinners. Blood thinner is not a right term. Sometimes when we use blood thinners, antiplatelets also come in that. So I'll focus my talk on anticoagulants, which are commonly known as or called as a blood thinner. So when we need or when does the blood clot is a very clear when there's an injury to the blood vessel, plaque rupture is there, blood stress is there, especially when there is a atrial fibrillation, and in a atrial fibrillation, atriums are not able to pump the blood to the ventricles or to the so blood remains static there. So there is a chances of coagulation of blood. In our body, we have a natural coagulants and anticoagulants, and whenever we find the procoagulants are dominant, so coagulation state appears. So we know that a drug that help preventing the clotting are anticoagulants, or clotting of the blood are called anticoagulants. Coagulation will occur instantly once a blood vessel has been severed. So we have an intrinsic and intrinsic pathways for this. This is a picture. This is a flow diagram, which we all know right from our first year of MBBS. But so we have two systems, extrinsic and intrinsic. Extrinsic is rapid, intrinsic is slightly slow. We monitor extrinsic with the prothrombin time or international normalized ratio, where the internal pathway we monitored by activated partial thromboplastin time. And we know that both the extrinsic and intrinsic pathways, they stimulate the factor 10 into an active factor. Further, this factor 10 converts the prothrombin into thrombin, and then the thrombin acts on a fibrinogen to convert into a fibrin monomer, and then finally fibrin polymer, and overcrossing of this happens. So if we want to block this, so most common target is a factor 10, which we can target. Of course, we can target any factor out of it, but the drugs which are available, they target factor 10, factor 2, that's the thrombin, and heparin is the one which really affect most of the clotting factors. And then when we say anticoagulants, oral coagulants, Coumarin and all that, Warfarin, they inhibit the vitamin K synthesis, and which is responsible for the formation of factor 2, 7, 9, and 10 in the liver. So all these things we'll be discussing today. When we say the targets in the drug, if we say the anticoagulants, we know that they are parenteral, they are oral. In a parenteral, we can have a target of a thrombin, that's a factor 2, then thrombin factor 10A, factor 10A, and the factor, these factors, if we see, we have targets like established anticoagulants. We have bivalirudin, which is specific to the thrombin or direct thrombin inhibitor. And then we have a heparin, which acts on a factor 10 and factor 2 both. So where the low molecular heparin has a more propensity to block the factor 10A than the factor 2. So this way, oral factors, if we see that, then we have a drugs which can act on a liver. Vitamin K antagonist are the one which can be targeted by this. So even the oral ones, if we see that, we have a drugs which directly inhibit thrombin, and they inhibit activated factor 10 also, like dabigatran, which was very commonly in market and in questions during the COVID, and many people, they consumed it also, dabigatran. And the rivaroxaban, apixaban, these are the drugs which oral, but specific to factor 10. So we'll be discussing most commonly drug use only, like heparin, low molecular weight heparin, fondaparinux, of course, we will use in light of a selection of the drug, and the vitamin K antagonist, of course, we'll discuss. So among the new anticoagulants, which we have, a dabigatran is not more very new, but it's a still new drug. So rivaroxaban, apixaban, we'll be discussing. So these are the factors which we have already discussed, pathway and the targets which we have, by which we can block either factor 10 or factor 2. So this is a journey of anticoagulants, developmental history. We see that, and the latest, if we see, we have direct thrombin inhibitor and a factor 10 inhibitor, that is a dabigatran, rivaroxaban, and apixaban are the relatively new drugs which have come in 2010 and 76. So if we say warfarin and heparin is really a longest history, and if we say the warfarin is still, we are struggling with it with more than 70 70 years, we are still finding a drug which is most ideal anticoagulant agent. So heparin, we all know it's a molecular weight of 10,000 to 20,000, contains polymer, 2 polymer sulfated disaccharide units. It's present in all tissues containing mast cells. Richest source are lung, liver, and intestinal mucosa. Bovine lungs and livers are used to extract the heparin, and so naturally heparin is available in the body, in the mast cells. So if you see the mechanism of action or the anticoagulant action of heparin, so it activates plasma antithrombin 3. And heparin uh, antithrombin 3 complex is formed, and then this complex binds to the clotting factor of intrinsic and common pathway, that is the factor 10A, 2, 9, 11, 12, and 13 activated. So this complex binds to almost most of the factors of intrinsic pathway and inactivate them, and they're unable to form the clot. So other actions of heparin are also there. They inhibit the platelet aggregation and prolongs the bleeding time. Heparin in low dose helps in lipemic clearance, and they reduces triglycerides. If you see the kinetic, we all know of the heparin is a well-known, well-used molecule. Of course, now it's not commonly used because low molecular heparin have the upper edge. So subcutaneous anticoagulant effect develops after 60 minutes, and bioavailability of heparin is inconsistent. So this is a problem with heparin. It's metabolized by heparinase enzyme, which is present in the liver. And if we see that it doesn't process blood-brain barrier and placenta. So I want to stress upon here, if you have to select a drug for a pregnancy anticoagulant, then heparin is still a drug of choice because it doesn't process placenta. So heparin should be mixed with penicillin, should not be mixed in the same syringe, and non-epinephrine in the same syringe for the infusion, and it will form the complex and it will be ineffective. Heparinized blood is not suitable for blood counts. We all know lab people, they take care of it. So this is the same summary which we have discussed, that is a partially degraded heparin and low molecular weight heparin appear in the urine. So it can be given subcutaneously, IV, and absorption is inconsistent, where the low molecular weight can be given subcutaneously and is a so I'll be focusing main either in any of the situation. These are the things which we need to be very careful. Bleeding due to overdose is common, most serious complication, and we should know that how to manage this complication. Thrombocytopenia, mild and transient, and heparin-induced thrombocytopenia is a troublesome situation, and we should know that if it happens, then how to switch over to the other agents. Transient and reversible alopecia is infrequent. Serum transaminase level may rise. Osteoporosis, use high dose for more than 1 year can cause osteoporosis, and hypersensitivity reactions are too rare. So contraindication the same, the side effect which is causes like a bleeding disorder or the history of heparin-induced HIT, which we say is a contraindication for the use of heparin. For the low molecular heparins, weight heparin are relatively safer, but not very safer. So if we get any situation like a HIT, then we have to see that which drug will be more appropriate for that situation. So we have a fondapaxine, which is really relatively safer, and oral also rivaroxaban, we can think of it. So severe hypertension, threatened abortion, hemorrhoids, GI bleed, there are chances of bleeding which will be difficult to stop without any intervention. Subcutaneous bacterial endocarditis, large malignancies, tuberculosis, ocular neurosurgery, lumbar puncture, chronic alcoholics, cirrhosis, renal failure are the contraindication for this use. Low molecular weight heparin, name suggests low molecular weight. High molecular or unfractioned heparin is 10,000 to 20,000 molecular weight, and this is 3,000 to 7,000, as isolated by different techniques. and molecular weight of less than 8,000 delta. So it's obtained by various techniques, depolymerization and all, and mechanism of action is it inhibits the factor 10A with a little effect of 2A. So this way it acts inducing conformational changes in antithrombin 3, hence low molecular weight heparin have a smaller effect on a partial prothrombin time, activated partial prothrombin time and whole blood clotting time than the normal heparin or unfractionated heparin. Also, they have a lesser antiplatelet action. So this we have to see that thrombocytopenia was more a problem with the heparin and a less with low molecular weight heparin. So lower incidence of hemorrhage complications and annulation primarily by renal excretion. So anything which is excreted through the renal system. So its use in renal failure will be a problem. So we have to be careful that drugs should move out of the body in a proper way. So these are the things which we should keep in mind, that what can be given, the drug which is, so if we say that absorption part is a better absorption, consistent absorption, 70 to 90%, longer and more consistent, mono-exponential half-life of 4 to 6 hours. So low molecular weight heparin can be given as a single daily dose, and with the heparin we need to give frequently. So indications: prophylaxis of deep vein thrombosis and pulmonary embolism in high-risk patients undergoing surgery. So treatment of deep vein thrombosis, unstable angina and myocardial infarction, they have a largely replaced continuous infusion of normal unfractionated heparin. To maintain patency of cannula and shunts for the dialysis patient, we use low molecular weight heparin. So these are some of the low molecular weight heparin. Out of these, enoxaparin and deltaparin are commonly used. So fondaparinix is a synthetic derivative of heparin. So it's a specific sequence that binds to antithrombin 3 with a high affinity to be selectively inhibiting factor 10 without binding thrombin 2. So bioavailability is 100% by subcutaneous injection, is still better, excreted unchanged in the kidney. So we have to see that which drug still will come and will be useful for renal patients. Direct thrombin inhibitor, the intravenous which we can use for as a direct thrombin inhibitor are the lipirudin, beviluridin. So out of these, lipirudin and beviluridin are being very commonly used drug, but not much as compared to the newer oral anticoagulant agents. So these are the oral coagulants which we'll be discussing. We'll be focusing on warfarin, dabigatran, rivaroxaban, and apixaban. These are the drugs which will be just overviewing these drugs. So 70 years old, still causing problem, warfarin, and still we have to stick to it. Warfarin, most widely used anticoagulant in the world, and it's a water-soluble vitamin K antagonist, low cost and highly effective if given in right way. If we compare the warfarin cost with the new oral anticoagulant agents, and in an Indian scenario.
Dr. Rehan, you've been muted by mistake, I think. Dr. Rehan? Dr. Rehan?
Oh, sorry.
Yeah. That's okay. That's okay. Sorry. It was just on the slide.
Yeah. This is a slide where I was muted?
Yes.
Okay, fine. So warfarin being a most widely used anticoagulant in the world, and it's a water-soluble vitamin K antagonist. low cost and highly effective. This is a very important thing, that's a highly effective and a low cost. The only thing that we have to see that how much time does it take to produce this anticoagulant effect. So it's not instant like a heparin. So it takes 3 to 5 days time for it to act. So there has to be a overlap when we give the this drug. We have to give a cover with the low molecular weight heparin or heparin. So if we focus on a cost of these two product of product of a warfarin and product of cost of NOAC, new oral anticoagulant agent, the cost of the NOAC anything will be between 28,000 for a year in India, and where it will be just 1,600 rupee for a warfarin for medium to high company cost. So it has to be given in a right way. This is a challenge. So this we all know that how vitamin K synthesis is inhibited, or it antagonizes the conversion of vitamin K epoxide to vitamin K hydroxyquinone, and hydroquinone is a one, vitamin K hydroquinone is a one which is required to convert the des-carboxyprothrombin factors 7, 9, and 10 to the prothrombin factors 7, 9, and 10. So this way it blocks the oral synthesis of these clotting factors in the liver. So if you see the half-life of these vitamin K dependent proteins, so factor 2 half-life is 72 hours, which is a maximum. If we inhibit this, it will produce as anticoagulant effect for 72 hours, where the factor 10 is for 36 hours. So the peak anticoagulant effect may be delayed by 72 to 96 hours. If we see the protein S and C, which are again procoagulant, if we inhibit them, then it's almost like a 3 days it produces its effect. So 3 days on an average, if we say that anticoagulant effect may be delayed. So the warfarin which is available in a RNS isomers, S isomer is more active, rapidly and completely absorbed from the GIT. Blood levels peak around 90 minutes of the administration. 90% of the circulating warfarin is protein bound. Now this is very important aspect. When any drug which is very highly protein bound to the albumin, if the body or the protein levels of the body goes down, means in the blood albumin goes down, so free form of warfarin will be available, and the vice versa. Any drug which binds to the same place can displace it and can cause a bleeding problem. So that's why we have to be very careful about this. So plasma half-life 36 to 42 hours, and only small fraction of unbound is biologically active because it's more is protein bound. So it accumulates in a liver and metabolized by a cytochrome P269 mediated oxidation metabolism. So this enzyme is problematic in Asians. Sometime we'll discuss that. If it is vitamin K oxidase receptor is enhanced or there is a genetic variation, then we see a lot of problem. So we should, that's why we should try to maintain the INR ratio and the APTT and the PT time well in the normal range. So dosing is 5 milligram per day. Low dose required for elderly patient having a risk of bleeding. Like if the patient is on aspirin, there is a chances of a risk of bleeding. So dose should be lower or reduced. Heart failure, liver disease, renal impairment, malnutrition. Malnutrition, again, protein levels will be, albumin level will be low. Thyroxine and myxedema, both are the problem. And thyroxine will have a more of the metabolism of this drug when myxedema. So opposite effect we will see. The Asian, they have a genetic variation in a hepatic enzyme, and high intake of vitamin K. The diet which is high in vitamin K, like green vegetables, broccoli, they have the high level. So these are the vitamin K which we should take almost daily, but not a very large quantity on a one particular day and then we miss whole month, that should not be done. So warfarin, this time to get the chronopharmacological optimized effect of the warfarin is in the evening, 6 p.m., which we normally don't do. So caution of vitamin K containing foods, we have discussed that eat the same amount from day to day, don't eat a lot one day and none the next. Why add concomitant parenteral anticoagulants? Why to add concomitant parenteral anticoagulant when we give the warfarin? We have discussed that because there is a lag period of 5 days for the warfarin to inhibit the vitamin K dependent clotting factors which are being formed in the liver. So it also reduces the endogenous anticoagulant like protein C and S. So commencement of oral anticoagulant therapy, we see that if the INR ratio, so how we should start the therapy whenever we want to give a anticoagulant therapy or a warfarin. Day 1 and 2, we should give 5 milligram each day if INR is 1.3. So INR, we all know how we calculate, and we take the PT time of the patient divided by PT time of the reference to the power ISI. So that is the international sensitivity index, and whatever value we get. So according to that, we decide that what is the INR value. If it is 1.3, this ratio, then for 2 days, then next day, third day, we again see the INR ratio. And if the INR ratio is less than 1.5, 10 milligram is given. If it is more than 3, then no drug is given. So depending upon this, on a 4th day, again, we do it. Initially, we check the INR ratio more frequently, maybe 2 to 3 times in a day, then 3 times in a week, and then subsequently we do it at a stage. So 3 times weekly for 2 weeks, because day 1 and 2, and then the dose once stabilized and a warfarin dose is known, then INR every 3 to 4 weeks or more frequently if it is to be required. So this is a thing which we should know, that regulation of the dose with warfarin is important. In fact, with other anticoagulants also, because of its narrow therapeutic index. So we know what's the PT ratio and all. So most common indication of the targeted INR. If it's a proximal DVT, then 2.5 we should maintain. If it's a cardioversion, we should, before the cardioversion, we should maintain 3, and the post-cardioversion, we should maintain 2.5. And in an atrial fibrillation, 2.5 of the INR ratio will be good. So these are the indications for the warfarin. There's too much of the overlap in these: prostatic heart valve, venous thromboembolism, primary pulmonary hypertension, rarely after acute myocardial infarction. So heart valve prosthesis, we have been using it. Warfarin in venous thromboembolism, again, we try to maintain the ratio between 2 to 3, and after 5 days, warfarin alone can be continued for at least 3 months. So earlier we have to give parenteral heparin, and then after 5 days we have to continue it alone. So optimal duration depends upon the setting, but it may be 3 months, or the setting is like this, it may be continuous for a longer period. So this is optimal durations which we see. If it's a first provoked pulmonary embolism, proximal leg DVT, 3 to 6 months, and if it's a second provoked venous thromboembolism, duration is uncertain, it may be longer. Unprovoked, second unprovoked calf deep vein thrombosis, again, it is uncertain. So normally we take 3 months, and if it's a subsequent unprovoked phenomena of VTE, then it may be uncertain. So side effects are the same which we have done with the heparin and the HIT which we have seen. So here also we get the bleeding problems, skin necrosis, which is a troublesome at times. Purple toe syndrome is a troublesome. We should identify it. We should check the platelet count, and we should intervene. Teratogenicity is a problem. Here, osteoporosis and other agranulocytosis. Will quickly go through what's to be done for this. If there is a bleeding, most common complication is a bleeding in the form of mild as a epistaxis, severe as a GIT bleeding, life-threatening intracranial bleed will be a problem. So major role of the bleeding defined as any visit to the hospital for hemorrhages 1 to 3% per year. Half of the complication occur because of the INR exceeds the therapeutic range, so it has to be very carefully monitored. So can be minimized by keeping INR in a therapeutic range. So these are the intervention and the therapeutic ranges which we see. And if there is a bleeding and INR ratio is 3.5 to 4.5, the only thing, don't give the next dose of warfarin until INR is in the therapeutic range, or decrease the warfarin dose. So if it is more than 9, and then we have to give vitamin K 2 to 3 milligrams. So higher the dose of vitamin K can be administered if more rapid reversal of the INR is required. So that this is a algorithm by which we have to take care of the bleeding complication. So symptomatic pressure with the patients with the raised INR, we see that the mild bleeding, withhold this, severe bleeding, vitamin K 10 milligrams low, and prostatic valve patient, if it's there, vitamin K should be strictly avoided unless there is a life-threatening situation, because intracranial bleed and the valve thrombosis can occur. So this is again the evidence of, if we see that oral vitamin K antagonist, we see that their efficacy is time to effect is 24 hours. Effect of duration of effect is in days, and evidence of efficacy for warfarin reversal is very good, and risk of thrombosis is not seen. So this way, if we see that plasma frozen acts immediately, and 12 to 24 hour duration of effect, and the reversal is good. So if you see that reversal of this, we see best with the oral vitamin K, intravenous vitamin K antidote. So the best effect we see with this. So recombinant factor 7A can also be given. Skin necrosis occurs in 2 to 5 days after initiation of a warfarin, and usually occur after high dose of warfarin. And the typical presentation is well demarcated erythema, and I'm very sure each one of you must have seen this complication. And the lesion from the thigh, buttocks, breast, and the toe, typically the center of the lesion becomes progressively necrotic, and biopsy is to be taken. This is a typical picture of the warfarin-induced skin necrosis on the lower abdomen and the breast. So mechanism, we know exact is not known, but precipitation fall in the plasma protein CSN can cause. So treatment is the discontinuation of the warfarin and reversal with the vitamin K if needed. And alternative anticoagulant should be thought. Low molecular weight heparin or a heparin is a better choice to be given to a patient with thrombosis. Vitamins, protein C concentrate or recombinant activated protein C may accelerate healing of the skin lesion in the protein C deficient patient. So we should assess the protein C levels also. So prevention start with a low dose of warfarin with known protein C and S deficiency, overlapping with the parenteral anticoagulant when initiation of the therapy is there. Purple 2, we have all seen the extremely uncommon cutaneous lesion. And if it happens, then basically it's due to the release of the atheromatous plaque, emboli, and if it happens, then we should discontinue warfarin, and if then alternative one, if it's really important, we should do that. We should be very careful not to give warfarin in pregnancy and first trimester mainly. It can cause this problem, we all know. Osteoporosis, long-term, more than 1 year, can cause 60% increase in risk of osteoporosis, related fracture in men. And basically, vitamin K is necessary for the bone health. And when we block this vitamin K synthesis can create a trouble. So drug interactions, we know that drug inducers, drug inhibitor, and the drugs which causes displacement of the warfarin from the protein binding site albumin can cause problem, either maybe increase in warfarin effect or decrease in warfarin effect. So these are some of the drugs which can cause interaction with the warfarin. So in a special condition like pregnancy, if we see that fetal abnormality in a first trimester and intracranial hemorrhage in a baby can occur if it passes through the birth canal in a third trimester. So because of this, warfarin is contraindicated in first trimester. Warfarin does not cross the breast milk and it's safe for nursing mothers. So these are the bridging therapy which we were talking earlier. So bridging is very important. Bridging with the treatment with heparin, not required if it's a venous thromboembolism. Last episode is in more than 3 months ago, and a bridging with the treatment with the dose heparin considered last episode within 3 months, and atrial fibrillation, not required at the atrial fibrillation with a no prior stroke or the transient ischemic attack and with the multiple other risks. So this way we decide whether it is required or not. These are the risk evaluations. So we evaluate how much is the risk, which procedure we are going to do. So according to that, we recommend the things that for a high risk procedure, discontinue warfarin 3 to 5 days before the procedure. And for the low risk, no change in anticoagulant unless the INR ratio is more than 3. So these are the recommendations depending upon a risk we evaluate. So we will touch some of the newer oral anticoagulants. So why we need the alternatives to warfarin, and still warfarin is troubling our patients. So it's a warfarin is narrow therapeutic index, slow onset of action, 5 days of time it takes, slow onset of action, long duration of action. That is also a trouble. So multiple drug and dietary interactions are there. We have seen that even in broccoli can cause interaction with it if it's taken in a large amount, and monitoring required to maintain in therapeutic range. Difficult to manage for invasive procedure, underuse of therapy due to the fear of adverse effect, and the complexity of the management is there. Efficacy dependent upon infrastructure, time in therapeutic range is associated with the improved safety and efficacy. Time in therapeutic range is greater in countries where the more sophisticated healthcare infrastructure is there. So what are the attributes of the ideal? If we see that it should be orally, rapid onset of action. So what are all the problems of warfarin should not be there in an ideal anticoagulant? A wide therapeutic range should be there, and the predictable therapeutic effect with a fixed and a weight-based doses, no food and drug-drug interaction, no monitoring required. This is an important thing because in a low-resource country and the at a PSC or of course at a PSC many things cannot be done, but it should be easy to do that. Like some of the new drugs that really they doesn't require much of the monitoring, dabigatran and also well-defined pharmacokinetic in renal and hepatic disease and easily reversible and should be cost-effective, which is not there with NOAC. It's the same. Most of the new drugs, rivaroxaban and apixaban, they act on a factor 10. They inhibit the factor 10, where there are oral direct thrombin inhibitors like dabigatran, which we will discuss. So these are the emerging therapies. These are the drugs which we'll discuss. Dabigatran, factor 2A inhibitor. It's a prolonged drug and does not exhibit any pharmacological activity. So once it enters into the body, then it becomes converts into active form. So they're competitive, and the direct thrombin inhibitor, both and free clot-bound thrombin and thrombin-induced platelet aggregation are inhibited in the active moieties. So it's absorbed. Absolute bioavailability of a dabigatran means 100% absorbed. This is a plus point thing. And it then approximately, if we see that 90% of it is excreted unchanged in the urine. So Cmax is 1 hour, So maximum concentration is at 1 hour post-administration. In the fasted state, co-administration with a high-fat meal delay the time to Cmax, and it may administer with or without food. That's the plus point of this. So metabolized by cytochrome P453A4 isozyme in clinically insignificant, no dose modification required in hepatic impairment. So it's also substrate for a P-glycoprotein, which is a transmembrane pump expelling drug out of the cell. So P-glycoprotein inhibitor can increase wherever the inducer may reduce the dabigatran level in the plasma. This is a drug-drug interaction of this. Pharmacodynamically, it's a APTT which targets the intrinsic pathway of the coagulation, thrombin clotting time, which directly assists the activity of the thrombin in the plasma sample, and the Heparin clotting time, which is a specific assay for thrombin generation. So we say that ETT-SA is the most sensitive to prolongation of a dabigatran, followed by Heparin clotting time and APTT. So if we say that indications of this are reduction in stroke and systemic embolism in a non-vascular atrial fibrillation, and the treatment of deep vein thrombosis, pulmonary embolism. So we see reduction in the risk of the recurrence of the deep venous thromboembolism and the pulmonary embolism. So these are the recommendations and their doses, which depends upon the creatinine clearance, reduction in risk of stroke and systemic embolism in the non-vascular atrial fibrillation. Doses should be according to the renal clearance. So if the renal clearance is very low, dosing recommendation cannot be provided. So if the patient is on dialysis. Some special point to be mentioned of the dabigatran is not given to the at a scheduled time. The dose should be taken as soon as possible on the same day. The mixed dose should be skipped if it cannot be taken at least 6 hours before the next scheduled dose. So you can skip, otherwise at least 6 hours before the next schedule, you should not take the medicine. So dose should not be doubled, making the missed dose. So that's the problem. This is a pharmacotherapeutic effect, that is special molecule, and it's fibers that makes the active ingredient of the dabigatran capsule integrity and rendering the medication less effective. Converting patient, this we all know if the patient is on from to warfarin, if the patient is taking dabigatran, from warfarin to dabigatran, stop warfarin and start dabigatran once the INR fall below 2. So if the patient is on warfarin, can be converted into dabigatran. You have to check that. From dabigatran to warfarin, adjust the starting time of the warfarin based on the creatinine clearance. If the creatinine clearance is more than 50, then 3 days this overlap should be there. Before that, you can stop the dabigatran. And if it's less, then it is not recommended for a dialysing patient to do this. So converting from parenteral anticoagulant from and to parenteral anticoagulant, if the patient is on dabigatran, from parenteral anticoagulant to dabigatran, intermediate parenteral, start dabigatran 2 hours before the next dose, and the continuous parenteral anticoagulant. If heparin is taking, patient is taking, then start dabigatran at the time of stopping parenteral anticoagulant. So switch over time is less. So from the dabigatran to parenteral, so wait for 12 hours once the dabigatran, because depending upon the renal clearance, and if it is renal clearance is less than 30, more than 30, then 12 hours. If it is less than 30, then 24 hours. The gap should be given in the dabigatran before starting parenteral anticoagulants. So these are the same algorithms, that timing of discontinuation of the therapy. If it's a moderate bleeding risk, then we discontinue dabigatran 1 to 2 days, and if it's a high risk, then 2 to 3 days. depending upon a renal clearance again. So monitoring anticoagulant effect of the dabigatran need not to assess regularly in the setting with the emergency surgery. So this is a plus point of the in emergency. Most accessible tests are the thrombin clotting factor and activated partial thromboplastin. Time should be monitored. So antidote, specific antidote is not available, and though limited data is there on this, adverse effects remain same in a GI dyspepsia in 12% of the patient. GERD can occur, esophagitis can occur, and hypersensitivity reaction occurs in less than 0.1% of the patient taking dabigatran. So, in unexplained increase in acute MI has been seen in dabigatran group versus Warfarin. So, though the small, there's only 0.2% around increase in a risk of acute myocardial infarction in a REHAN trial. So contraindication, again, this we have already discussed that youths were more likely to experience stroke, heart attack, and a blood clot forming on a mechanical heart valve than those who are on a warfarin. So this is a status of dabigatran, which is a slightly negative aspect of it. So drug interaction we have already discussed, peak glycoprotein inducer, and it can interact with the rifampicin, which is an enzyme inducer. John Watts reduces its anticoagulant effect, and other drugs which affect the peak glycoprotein inducement, like verapamil and amiodarone. So they can also cause increase in plasma level. So approximant, it's a last drug which we will discuss in this group, and the rivaroxaban. Approximant is a very commonly used drug in a present scenario. Directly inhibitor of thrombin inhibitor, that's a factor 10A, 7 to 9 hours is the half-life, and bioavailability is 180 to 100%. Metabolized by cytochrome T4A system in liver. So conclusion of the rocket trial on rivaroxaban was a patient with atrial fibrillation. Rivaroxaban was non-inferior to the warfarin. So this is the status of these drugs. So efficacy-wise, we see that warfarin is still, but it's difficult to maintain, and more of the drug interactions which we see with warfarin. So rivaroxaban is slightly better pharmacology. To reduce the risk of a DVT and PE in the patient, so these are the therapeutic indications approved by FDA: prevention of thromboembolism, stroke in a patient with non-vascular, deep vein thrombosis, pulmonary embolism, as well as reduction in a risk of recurrent DVT. So doses of rivaroxaban is 20 milligram once daily, prophylactically 10 milligram per daily. And I request that we should always check the dose. We can use compendium to confirm the dose before we give. So being it drug, in fact, we should do this with every drug, but especially with a drug with a narrow therapeutic index. So contraindicated in severe renal failure. So no dose adjustment for a body use. So these are the, again, depending on a dosage, on an indication, according to their renal clearance. Antidote like dabigatran, no specific dose is available. Unlike dabigatran, rivaroxaban is not hydrolyzable because of the high degree of albumin binding. Even dialysis will not be useful in taking of the medicine because it's bound to the albumin. So some effects like a 4-factor PCC, EBC in an acute major hospital or the clinical bleeding, and the clinical data are still lacking on it. So every day we get more data and we get more confident. So these are the drug interactions which we have already discussed. Approximant, same group, same mechanism of action, slightly longer half-life, and have excellent bioavailability, 66%, metabolized in the liver, 25% is renally excreted, so no dose adjustment is required for renal failure patients. So it has an upper edge over the others for the renal problem. 75% of it is excreted in the feces. So drug interactions are minimally with peak glycogen, hence its effect is not affected significantly. And no clinical significant drug interactions we have seen recommended for risk of stroke, dangerous blood clot, suspect embolism, in a patient with atrial fibrillation that's not caused by arch wall. So these are the recommended doses, reduction of stroke and systemic embolism. If you see, then 5 milligram taken orally twice a daily, and we can recommend lesser dose for a patient more than 80 years, body weight more than 60 kg, less than 60 kg, and the written clearance is 1.5 milligram. So similarly, 2.5 milligram dose for deep vein thrombosis following hip and the renal replacement, and the treatment of DVT and pulmonary embolism. 5 milligram again for the risk of recurrence of DVT is 2.5 milligram. So prophylaxis dose is 2.5 milligram and the treatment dose is 5 milligram. So if we see that clinical challenge, we see that it's not that newer oral anticoagulants are very safe, no validated test for measuring anticoagulant effect, no established therapeutic range, no antidote for most of the agent, assessment of the compliance more difficult than the vitamin A antagonist, and potential of unknown long-term side effects are still there. Cost is again a problem. Balancing cost against efficacy, we have to see that as we discussed that it's a 15 to 20 times more costly. Lack of head-to-head, these are the different targets, and this is the status of a different new oral anticoagulants, their comparison with the Warfarin. If you see one, the antidote of the treatment of the bleeding is Warfarin is available, where there is not available for dabigatran, rivaroxaban, and reflexaban. So drug interactions, we have more with this. In fact, all the drugs, all the groups are interacting well. And we monitor warfarin with INR adjustment, where it's not needed in dabigatran and other new anticoagulants. So these are the benefit of a new oral anticoagulant agents. So we know it's the best to treat with the warfarin. There's a good level of control with the warfarin, renal failure patients, mechanical heart valve replacement, gastrointestinal disease, patient with elderly, poor compliance patient, drug costs, so they are best treated. This is the category of the patient which are treated best with the warfarin. So these are the explanation. We can have a discussion why all these things we require. We say the good level of control of because of its twice daily dose and greater risk of non-hemorrhagic side effects. So this is the reason that suggests that the patient values and preference should be influence the decision of the dabigatran. So renal failure, again, we have discussed that warfarin remains the treatment of choice for a patient with a calculated creatinine clearance close to or less than 30 milliliter per minute. Mechanical heart valve, recently FDA added contraindication to the dabigatran level, against which the drug in patient with the mechanical heart valve. So warfarin still holds its value here. So GIT, we have this low GIT bleeding is significantly increased in dabigatran. Rivaroxaban is also associated with a significant increase in risk of GI bleeding, and patient with the angiodysplasia, inflammatory bowel disease, and diverticulosis. These are the history of other form of GI bleed may experience deterioration on the treatment of dabigatran and rivaroxaban. So this is the explanation that why warfarin is still holds its importance in a gastrointestinal disease patient, and elderly. Rely trial also say the same. And the poor compliance, we know that to recommend a poor compliance with the treatment with warfarin because it's twice a day and cannot be seen as a candidate with dabigatran. So once a day, warfarin is once a day, dabigatran is twice a day. So compliance will be certainly better with the once a day dosage schedule. So cost, we have already discussed. The best patient with a newer anticoagulant, those should be treated with newer anticoagulant. Unexplained poor warfarin control, poor level of control because of the unavoidable drug interaction. New patient on an anticoagulant therapy for atrial fibrillation. So for these are newer drugs, they hold the things, and these are
Sir, we can't hear you. Sir, we've lost you there.
Dr. Rehan, we can't hear you.
Sir, we've lost you there.
I think there's some problem with his network. Maybe we can just. Dr. Rehan,
I think he's got disconnected.
he's here, but he's muted.
Am I audible?
Yes, yes, sir. Yes,
you
sir.
are.
Now we can hear you.
We can hear you, but your slides you'll have to restart. Like you'll have to post them again.
From unexplained poor warfarin control.
So, poor levels of control because of unavoidable drug-drug interaction.
Sir, you'll have to repost your screen, sir.
Okay.
Yes, sir.
Yes.
Okay. Thank you. Sorry. There was a call. I have made a hotspot, and that was the reason.
No, not a problem, sir.
So I'll make it a full.
So it is from unexplained poor warfarin control.
Okay. Poor level of control because of unavoidable drug-drug interaction. Why it should be preferred? Why newer oral complements should be preferred? Patient with a frequent need of the antibiotic treatment, chemotherapy, amiodarone, frequent use of the acetaminophen, azathioprine, or the large number of concomitant medication, particularly if the exposure to this medication varies, will probably do better with newer anticoagulants. So, because they're causing lesser drug-drug interactions. So, newer patients on anticoagulant therapy, and we see that for warfarin-naive patients who can afford newer agents, it is very tempting to go straight for the new anticoagulants to avoid the initial several weeks of frequent dosing adjustment of the warfarin. So compliance part for the new patient should be informed about the advantages and disadvantages of the alternative and allowing them to make an informed decision on their preferred treatment. So message is warfarin is not going anywhere. Patient with a stable INR in a therapeutic range best be left on warfarin. Other who better treated with warfarin are renal failure patient, mechanical heart valve, GIT disease, poor compliance patient, and the drug cost. And the further messages, group 1 patient should be candidate for a new, those who have a poor control because of the unavoidable drug-drug interaction, new patient on anticoagulant therapy for atrial fibrillation, unexplained poor warfarin control. It's important to establish that the unstable INR is not due to poor compliance. Dabigatran should be avoided in renal failure. Function is not so much of a problem with the rivaroxaban. So these are the status, and for when we select a drug for acute coronary syndrome patient, there are better data for rivaroxaban in a low dose as seen with the ATLAS trial. So I thank you very much for bearing and listening overview of these anticoagulant agents. So if we see that if we say the COVID part, if we see we may have a mild disease, we may have a moderate disease. When we say mild disease, we say the PREDA or the Caprini score we find in a mild disease. Border scale is 4 or the Caprini scale is less than 10, and the case is mild, and we need not to give any anticoagulants to COVID patient. So if we find that COVID score is more than equal to 4 and Caprini score is more than equal to 10, there is a moderate severity of the case of the COVID, then low molecular weight heparin should be considered, and we should give 4,000 international units once a day. And if we have the severe patient where we evaluate the patient with IST-H and a DIC score, if we find the score is less than 5, then low molecular weight heparin, 4,000 to 6,000 unit, we can 6,000 unit we can give daily, and if it is more than 5 or equal to 5, then low molecular weight heparin of 100 international units per kg body weight can be given. So this is about there's a very less data, and more data is coming about the
Sir, I have a few questions. One, you did mention that there is sometimes that unexplained skin necrosis that is seen with warfarin, even though it still remains probably the first choice in terms of its economic burden as well as its relative safety profile. In particularly in COVID, when we say that in our country we've been seeing mucormycosis, and mucor has a propensity for necrotic tissue and has angioinvasive potential. Wouldn't the newer agents be better? That's one. And second, in view of the same, I mean, COVID is also thrombogenic through the platelet pathway. What is the safest agent to preempt this thrombosis, to not let it proceed to clinically critical levels?
So again, we have to assess the patient on a Bradis and a Caprini score. According to that, we have to see, and if we have to see the newer agents. If we see, dabigatran has been tried, and this is a data which is available. Very good clinical trial in a COVID, they are not available. But if we see dabigatran data is available where it has been used.
Sir, in this group of doctors with Dr. K.K. Agarwal's philosophy on anticoagulants, he also used to say that warfarin is probably the easiest and the cheapest. However, he used to say that whichever we are comfortable with, dabigatran or rivaroxaban, he advocated that we should start early rather than late. I think Dr. J.S. Arora is also raising his hands. So, Dr. Arora?
Yes. Sir, I have a question. What is the limitations, or you can say precautions, to use newer anticoagulant like this rivaroxaban, dabigatran, apixaban in pediatrics, especially 12 to 18, because that we see very frequently, 12 to 18 age group, and their dose. Any modification in dose?
Rivaroxaban, the benefit, if we see, it doesn't, the efficacy and safety, if we see, of rivaroxaban and apixaban, it's both have the same efficacy, and the bridging therapy in very ultra cases is required, otherwise we don't require. No lab monitoring is required. This is a benefit of rivaroxaban. And rivaroxaban and refluxaban, they are also very safe in hepatic and renal patient, and dose modification is not required. So these are the benefits of these rivaroxaban and approxaban, which are direct thrombin inhibitors.
So these can be given in adolescent age group without dose modifications.
See, dose modification for children, yes, without dose modification, yes, we can give if there is an indication. 2.5 milligram we can start with for a therapeutic purpose, treatment purpose.
Sir, another question. Acetrom is quite frequently used for this heart valve processes and instead of warfarin. So what is warfarin and acetrom? What is your
Ecumerol, warfarin is certainly better. We have a better international data on a warfarin than ecumeron, like vitamin K antagonist if we see. So depending upon a situation that what we are looking for and what is our target and what is our patient, according to that we can select like vitamin K antagonist. Both are the same will function. Warfarin is a more data available. Efficacy of both the things are same. Safety of warfarin is better. Bridging required for both the things of the 5 to 7 days. PT and INR monitoring required again. So the only thing, many things are same, but warfarin has a more experience and published data and good level of data with the warfarin we have.
Yes, Dr. Vadva.
Thanks for an excellent talk, Dr. Harmeet. Newer and oral anticoagulants definitely have their advantages, but non-availability of antidotes remains a big cause for concern for clinicians. In the foreseeable future, is it likely that we will have some antidotes for these drugs?
Yes, certainly. As the more and more data is accumulated and more of the cases of come across, certainly drug development process is primarily based on the challenges which we get from the market. And once we have the antidotes, certainly they will have an upper edge over the warfarin. That's the reason that still warfarin is having a better edge over newer anticoagulants despite their pharmacological profile better on certain aspects.
Yes. I think.
Hello. Hello.
Yes.
Yeah, I'm Dr. Poddar. I think in contraindications of usage for low molecular weight heparin, you have, I think you have written piles also. So piles is not necessarily bleeding piles. So
yes,
bleeding piles may be contraindication, but
yes.
piles is very common disease.
Yes,
so all
yes. Yes, I fully agree with you. If it's actively bleeding piles, then there has to be a thing. So where in an earlier question, I would like to add here, where the no doubt for the newer anticoagulants, antidote is not available, but activated prothrombin complex concentrate has been tried, and recombinant factor 7A has been tried for this, and concentrate of the factor and tried, and hemodialysis has been tried. So over a period of time, maybe we get the good data for antidote of newer anticoagulant agents, but certainly potassium sulfate and the vitamin K are not helpful in overdosage of the newer anticoagulant agents. So these are the other strategies which have been tried to overcome the bleeding problem of newer anticoagulant agents. And certainly, if a say bleeding, actively bleeding pile is a concern. Thank you, Doctor.
Thank you.
One thing more, during COVID, we have been using this newer anticoagulants for 4 weeks or more, especially when D-dimer is high. So how long can we, if D-dimer is high, how long we can use this rivaroxaban or apixaban or dabigatran?
So we say the half-life of D-dimer is very short, and D-dimer is a procoagulant. In fact, COVID is a procoagulant situation. So once it is done, so up to 18 days we can certainly use. So what the literature says for if we have given it for prophylaxis 18 days, and if we have started, then not more than 3 months it should.
Sir, in the moderate to severe cases of COVID, the thrombogenicity has been shown to predispose to DVT as well as to PE. And in those cases, then would you recommend prolonging the use of anticoagulation?
Then we have to treat this
as PE
in a deep vein thrombosis.
DVT and PE, then we have to treat them as DVT and PE.
Yes, then we have to follow the exact schedule whatever we have for DVT.
And also, sir, is there a role for anti-TNF alpha drugs like Trental, pentoxifylline, etc.? And how would they interact with these anticoagulants?
Pentoxifylline have no role as a blood thinner. It has an anti-rehatic drug, only improves the blood flow, doesn't cause that. So of course interaction may have there, but there's no benefit of a pentoxifylline in as a blood thinner or as an anticoagulant. So which you said for deep vein thrombosis here, yes. So this is about what I said about your question. Sorry, what we were talking.
Sir,
pentoxifylline.
Right.
So pentoxifylline has not. I'm not saying approved. Is not approved for any deep vein thrombosis or pulmonary embolism, though we are using it.
Sir, we are seeing a lot of skin lesions, and we see that they kind of satisfy the criteria for stasis ulcers or for end arthritis kind of thing, where probably adding pentoxifylline would work, but would it then interfere with our anticoagulant therapy?
Yeah, I had to check that. What is the interaction of pentoxifylline with the warfarin and all? I need to check. So as such, I believe there is no interaction as such.
And sir, I mean, even in DVT, pentoxifylline used to be. Of course, I'm not a physician. I'm not a surgeon. I'm an ENT surgeon. So pentoxifylline used to be used in. I remember from my times.
So pentoxifylline is more of the abused drug than the used drug. So just to believe that it will improve the blood flow.
But because sir, it does have anti-TNF alpha activity, so it might have a place in COVID, because chemically COVID is increasing TNF alpha, so it might have a role.
Yes. See, if we say that way, the drug which is most effective in inhibiting all these cytokine is a steroid. And we have seen what the steroids were doing. So yes, you're right. If we say improving the blood flow to the necrosed area, yes, it improves the blood flow. But anticoagulant effect is difficult to say. even in some of the ENT condition, pentoxifylline has been tried. And
yes, I know, and that is why, I went into the chemistry.
You're very right. In a CNS, transient ischemic attack, and many more conditions, pentoxifylline was in use.
So I that's why I went into the chemistry of pentoxifylline. So it has very few side effects, but it probably could have a role in.
So see, one is recommended dose, off-label use. Yes, we are using it.
Yes.
So, but it hasn't translated into good literature to say that it has a beneficial edge over others.
Okay. Thank you, sir. Thank you so much. Dr. Podar, you will have to unmute to ask your question.
Yes, we have seen in COVID times many cases of mesenteric vein thrombosis, artery thrombosis leading to intestinal gangrene. Even in the patients who were not apparently suffering from COVID, they didn't suffer from COVID, they were vaccinated, but 6 months later after vaccine, they presented with gangrene of intestine with thrombosis of mesenteric artery. So what could have been done to prevent those cases?
After 6 months, it's very difficult to say whether it is really because of one of the COVID complication, or it's is post-vaccination or adverse event following immunization. 6 months is not a very good temporal reason. If it's a arterial thrombosis, then once the thrombosis has happened, anticoagulants are not going to benefit the patient more. So this way we say that yes, a heparin should be, or low fraction heparin should come in this point, and where aspirin and clopidogrel to prevent the re-occlusion if there is a such problem, arterial thrombosis can be given to prevent the extension of the clot.
But could we have predicted those cases with follow-up D-dimers? It's not recommended. I know it's not recommended, but can we do D-dimer serially to rule out thrombosis? Yes.
Yes. D-dimer can be done. As I said earlier, it has a very short half-life, and it's not going to stay very high for a very long time. Yes, it should be done. Serially, it should be done. And accordingly, because in a COVID, most of the things are really hit and trial, which we are doing because of the lack of very good level of data. So this way, personal physician experience and situation is important, that how they manage the things according to the prevalent clinical situations and condition of the patient.
Right, sir. Okay, thank you.
Yeah. There's another question. If I even say 1 or 2 days dose or a few doses can lead to this bleeding with the newer anticoagulants, because I have seen a case in the COVID during even the first dose that the patient has epistoxis. So could it be related to anticoagulant or something else?
See, it depends what has been taken. If it is warfarin, it cannot do immediately. If it's a heparin, low dose heparin, unfractionated heparin, yes, it can. It can cause, if there is a micro bleed somewhere in a little area of the nose, yes, bleeding can occur.
So it was, I think, dabigatran or maybe rivaroxaban. I don't remember right now. But
likely rivaroxaban, because even I have seen quite a few bleeding incidences after rivaroxaban.
Yes, I think it was good.
Yes. So yes, any these new anticoagulants, they've been reported to cause bleeding like this. So we need to manage. So drop the dose and manage with this if it's a very, very normal thing. And then protocol will remain same as managing the bleeding as we do with the others. So pressure, okay, there's a one thing, stop the dose. And then,
muted. Dr. Meenakshi are muted.
Managing this bleeding, yes, rivaroxaban, approxaban can cause. You're very right, sir. So newer anticoagulants, even a single dose can cause bleeding if there is any bleeder at that place. Even anticoagulants has caused death of the many patients, those who recovered from the 25 on 25 score and they died of the GI bleed subsequently because patient was on steroid, and that is known to cause fragile blood vessels and bleeding, GI bleeds, and that leads to death of the patient, and patient could not reach to the hospital for blood transfusion, and we have to lose many patients like this.
If anyone has any other questions, can you please post it in the chat box, or you can raise your hand. We've almost crossed the 1.5 hour mark. So I think that's all the questions that we had for you, sir, today. Thank you. A very, very fruitful session, I would say. You know, in COVID times, we were using blood thinners very frequently, and of course, antiplatelets as well. And, you know, it was a trip back to memory lane where it felt like we were in a pharmacology class again. So a big thank you to you, sir, and and a big thank you to even to Dr. Arora for organizing this. And another vote of thanks to all of you present here today who are motivating us each day to continue Dr. K.K. Agarwal's dream of you know, educating everyone about about even the littlest of things. So a big thank you, and we'll be back next week.